when we started scanning the wrist, we were using these probes with a 12 megahertz frequency, 18 megahertz frequency, but we are increasingly using higher frequency probes, right? Now we have the majority of the places will be, we have the availability of a hockey stick probe, a short foot head probe, which makes the visualization of these small structures in a joint like wrist very, very easy. And we are increasingly seeing, higher resolution probes, higher frequency probes going up to 20 and even 30 megahertz, right? Which is going to just enable us to see smaller and smaller structures as we'll be seeing through the course of this topic. So we'll be dividing, looking at the wrist into the extensor or the dorsal compartment and the flexor compartment. So what we do is first position the patient. So similar to what you would do in an MRI, how you place the patient, how you place the coil. It is in fact even more important on ultrasound as to how we are positioning the patient, how we evaluate a particular structure. That's going to be very, very critical. So for the extensor compartment, well, the position is very easy. You can have the patient or even supine at times if you're comfortable. You have the wrist, on a table. And what you can do is maybe, keep a little bit of a pillow below the wrist joints. That will just help you to, see these structures a little bit better. So you give a little bit of flexion on the wrist and the structures on the extensor aspect can be much better visualized. So this is going to be a checklist when we look at the extensor compartment. So we'll be looking at the extensor compartment tendons. We'll be having a look at the scapholunate ligament. We'll be having a look at the distal radio-ulnar joint, the radiocarpal and the midcarpal joints, and we'll also be having a quick look at the radial nerve. So the extensor compartment, right? The extensor tendons, if you look at, they are divided into these multiple compartments. So what happens is you basically have this extensor sheath, right? And it dips at various levels and it, attaches to the bones. And this is what creates these different compartments, right? And each of these compartments contains a single or multiple tendons. So this is a very, very important thing, to know from an anatomical perspective as to which tendons are located in which compartment. So if you look at compartment 1 on the radial side, we have the abductor pollicis longus and the extensor pollicis brevis tendon. Then we have the extensor carpi radialis longus and the extensor carpi radialis brevis tendons in the compartment 2. Compartment 3 has a single tendon, which is the extensor pollicis longus tendon. In compartment 4, we have the extensor indicis proprius and the extensor digitorum longus tendons. In compartment 5, we have the single tendon of the extensor digiti quinti proprius. And in compartment 6, we have the extensor carpi ulnaris tendon. Right? So once we know that this is the anatomy that we're going to be looking at, we can now move on to looking at these tendons on the ultrasound. Now, what happens with ultrasound is if you keep your probe suddenly at one point, you're going to be lost with different, soft tissue structures which are going to be popping out. So it is very important that we have some form of a bony landmark in mind when you want to evaluate the tendons. So for the extensor compartment, the most important landmark is going to be this protuberance, which is the Lister's tubercle, right? So on the dorsal aspect of the hand, very, very important structure over here, which is the Lister's tubercle. Now, what this Lister's tubercle does is that it separates the compartment 2 tendons on the radial side with the compartment 3 tendon on the ulnar side. So the moment you keep your probe over here, again, mind you, we are going to be scanning this with a high frequency probe. Majority of the images that I'm going to be showing are with 12 megahertz. There are images with 18 megahertz or even 20 megahertz when needed, right? So generally what we do is, we start with say a 12 megahertz probe, get a good assessment of what exactly is happening. You may want to see the different compartments. And then once you narrow down on the pathology, you may move to a higher frequency transducer, something like an 18 or a 20 megahertz, and have a look at that particular area a little better, right? So again, coming back to our Lister's tubercle, On the radial side, we have the compartment 2, and on the ulnar side, we have the compartment 3 tendon. Now, once you have identified these tendons, it's always a good idea that we move back and forth along the length of the tendon so that you're looking at the pathologies in the short axis, and then you can also go in longitudinal plane and have a look at these tendons in long axis, and we'll see some examples a little later. Now, moving more onto the radial side, what we are trying to assess over here is the compartment 1 tendons. So for that, what we do is keep the hand in kind of a, mid supination pronation position, right? Maybe on a pillow, you can give a little bit of a flexion. And what you should see the moment you keep your probe on the radial styloid over here is this structure, which is the compartment 1 tendon. And this, again, as we saw, it comprises of 2 tendons. You have the abductor pollicis longus tendon and the extensor pollicis brevis tendon. Majority of the times, this is covered by a single retinaculum, which appears like this hypoechoic structure, what we can see over here, right? But at times, you can have a septum, and these tendons may be divided. So you may see a different extensor pollicis brevis tendon, and you may see a separate abductor pollicis longus tendon. Even as far as the abductor pollicis longus tendon is concerned, there may be, multiple kind of a pennate, multi-pennate kind of appearance, multiple, sleeves to the tendon. So we have to be a little careful. And this assumes more importance when you're going to be injecting maybe a steroid or some other drug in this area, and you want to know which is the tendon which is affected so that you can, put the steroid in that particular area to relieve the patients of its symptoms. Now, coming back to our compartment 4 tendons, how do I come back over here? Well, I go back to my Lister's tubercle. I know next to the Lister's is the compartment 3, and I move a little more onto the ulnar side, and I'm able to see the compartment 4 tendons, right? So the compartment 4 tendons, what you should keep in mind is that the synovium the retinaculum actually, sorry, gets a little bit thickened over here, if you can see this image over here. So this should not be mistaken for a thickening. This is the natural, appearance of the retinaculum in this area, right? And the other thing you can do is, because it's a little difficult to identify the separate tendons, you can ask the patient to kind of, just wriggle his fingers, and you will be able to see the movements of these tendons individually. So you know which tendon is going to which finger. Also, as you move a little more distally, you can see the tendons separating a little bit better, and you can identify to which finger, which extensor tendon is traversing. So that is about the compartment 4 and the compartment 5 tendons. And next, coming to the compartment 6 tendon. So what we do is keep the hand in a radial deviation position, and we image over the ulnar styloid process. And the moment you image over this ulnar styloid process, you should be able to see this tendon sitting right over here, which is the extensor carpi ulnaris tendon. Now, also, just below the extensor carpi ulnaris tendon, if you look at this structure, what you are able to see is, a triangular echogenic, inverted triangular echogenic structure like this, which is actually your triangular fibrocartilage complex. Now, the triangular fibrocartilage complex is actually a complex structure with, formed with multiple structures. And we are not really able to see the entire TFCC very well, but we are able to visualize the superficial portion of the TFCC quite well using our ultrasound. Now, a very interesting thing happens with the tendons is that when you trace these tendons back, right, if you go towards your arm, your forearm, what you will see is that the tendons are actually not traversing in a straight line, right? So they are actually crossing over each other, and this crossing is what is called as the intersections. right? So there are two intersections. One is a proximal intersection, which is about 4 centimeters proximal to the Lister's tubercle. And here what happens is that the compartment 1 crosses the compartment 2 tendon, right? So you have the compartment 1 tendon crossing the compartment 2 tendons. And why is this important? Because when you have a situation where, maybe this guy is a sportsman or whatever, there's maybe playing a lot of racket sports or whatever, then if there is a repetitive irritation over here, this can cause a tenosynovitis at this level, and this more often affects the second compartment tendon. Okay, so that is the clinical importance of this crossing over. Similarly, if you move just distal to the Lister's tubercle, what you see over here is that there is another tendon. This is the compartment 3 tendon, which is crossing over the compartment 2 tendon, right? So again, proximally, we saw it was the first compartment tendons. Distally, it is the third compartment tendon, which is crossing the compartment 2 over here. You can see the crossover very well. And again, this assumes importance because this can be prone to tenosynovitis because of repeated friction. And also what happens over here is that the sheets of this compartment 2 and the compartment 3 tendons actually communicate with a foramen, right? And as a result of this, if you have a tenosynovitis of compartment 3, this can potentially spread to the compartment 2 tendon as well. Now, next, moving on to our distal radioulnar joint space. So as we move a little more distally, we are able to see the distal radioulnar joint space. This is how the radius will appear. This will be your ulna. And we have to watch out for the presence of any synovial thickening or maybe even, degenerative changes which can come up over here. Now, once you look at in this area in a longitudinal section, you are able to see the radiocarpal and the midcarpal joint space as well, right? So in the longitudinal position of your probe, you are able to see the radius over here. You have the lunate, the capitate, and distally, you have the head of the metacarpal. And again, why is it important to have a look at this? Because you may have this area filling up with fluid. There may be area of synovitis. And this is, again, important to identify when you're doing a scan. Next, another structure that we look at is the scapholunate ligament. So how do we look at the scapholunate ligament? Well, we come back to our Lister's tubercle area and go a little more distally, and with the hand in a ulnar deviation or ulnar deviation of the wrist rather, we should be able to see this dorsal bundle of the scapholunate ligament. Again, it may not be the best evaluation of the scapholunate ligament, but at least the dorsal bundle can be decently visualized. Now, this is one of the last structures that we're going to be looking at on the dorsal surface, and that is going to be your radial artery and the nerve, right? So if you look at the distal, if you look at the proximal aspect of the wrist, you are able to see the radial artery, right, somewhere over here on the flexor side actually. And as you trace that down, you are able to see the nerve, traversing along the radial artery. And then what happens is that the nerve actually slips from or rather snaps from the ventral to the dorsal aspect of the wrist over the compartment 1 tendon, right? So if you look at this video a little properly, you can see that this is the radial nerve, which is snapping from the ventral to the dorsal aspect. This is just going very close to the cephalic vein. And again, this is important because sometimes you may identify some neuromas over here, or at times, if you're injecting the compartment 1 tendon with a steroid, which is frequently done with a Descartes stenosynovitis, you may actually, you have to be sure that you're not injuring the nerve in any which way while doing this injection. So next, coming to the flexor or the volar compartment. Again, the positioning over here is very simple. You can again have this patient either sitting on a table or at times I even do this with a supine position. You can keep the hand on a pillow, but this is not always really necessary. It's quite easy to analyze the flexor compartment. So as far as the flexor compartment is concerned, what are we trying to identify? We are trying to identify the most important structure, which is the carpal tunnel. I'm sure everyone has heard of that. We'll be looking at the flexor tendons. We'll be looking at the median nerve very importantly, and then the Guyot-Skinner. So the carpal tunnel, as we know, is a fibro-osseous tunnel, right, which is bounded proximally by the scaphoid and the pisiform, and distally you have the trapezoid and the hamate. And this is covered by this transverse carpal ligament, which is, kind of a trapezoidal shaped ligament, which covers or it forms the roof of this fibro-osseous tunnel. So how do we identify this on ultrasound? It's fairly simple. Again, what we do is go back to identifying our bony landmarks. So as far as the proximal aspect of the carpal tunnel is concerned, what we do is we identify the bony landmarks of the scaphoid and the pisiform. And once we keep our probes, probe with the edges joining these two bones, we should be able to identify the proximal aspect of the carpal tunnel. The other landmark which we can use to identify this is actually look at the palmar crease, right? So the proximal aspect of the carpal tunnel corresponds somewhere to the palmar crease. So this is again a landmark which you can use to identify the carpal tunnel. As you move a little more distally, you can identify the bony landmarks of the trapezium and the hook of the hamate. And this is the distal portion of your carpal tunnel, right? And if you look at this, there's this subtle hypoechoic structure, which is, traversing on top, forming the roof. This is actually your flexor retinaculum. And lying underneath, below these flexor retinaculums are the flexor retinaculum is the content of the carpal tunnel, which is formed predominantly by the flexor tendon and your median nerve, right? So once you are looking, once you have identified the boundaries of the carpal tunnel and you start looking inside the carpal tunnel, what you want to identify is these tendons. So you have four flexor digitorum superficialis tendons, you have four flexor profundus tendon. Next to that, you have the flexor pollicis longus tendon, right? So these are the important tendons that we want to identify. And it's fairly easy. It may be a little challenging to identify these tendons and separate them out, at the level of the carpal tunnel, because the other problem which happens over here is something called as an anisotropy, right? So because of that, the tendons may appear a little hypoechoic at times. It may be a little confusing to identify the tendons. But if you rock the probe, just angulate the probe little proximally and distally, you will be able to identify these tendons. So you can see that the tendons are actually changing in color from black to white, right? So it is turning from hypoechoic to hyperechoic, and this is definitely a tendon. And if you see the structure sitting on top over here, which is not really changing in appearance when you're toggling the probe, this is actually your median nerve, right? So this is the way you can really identify the flexor tendons. And once you have identified the flexor tendons, you can move distally and identify the flexor tendons going to the individual digits, right? Which you may need to do in case of a trauma or you want to evaluate any other pathology involving the flexor tendons. Then the other important structure over here, like we mentioned, is the median nerve. So the median nerve, I told you what happens is if you toggle the probe over here, you should be able to identify this as this, hypoechoic structure not changing in echogenicity. And if you look at it very properly in the axial section, you get this kind of a honeycomb pattern, right? So you see this hypoechoic and hyperechoic areas. This is a very classical appearance of your median nerve. So even the median nerve, you can trace it distally. You can look at the branches of the median nerve, the sensory branches, the motor branches, right? It can be identified with a high resolution ultrasound. Now, moving on from the carpal tunnel, we move on to the ulnar aspect, and here what we identify is the Guyon's canal, right? So the Guyon's canal is formed, the roof of the Guyon's canal is formed by the volar carpal ligament. The floor is formed by the transverse carpal ligament or the flexor retinaculum, which we saw. On the radial side, you have the hook of the hamate, and the medial border is formed by the pisiform bone. And what is lying within this Guyon's canal is actually your ulnar artery. And next to that, what is sitting over here is your ulnar nerve, right? So this is again something that we do try to evaluate if there are suspected entrapments of the ulnar nerve. The other important thing is as you trace this ulnar nerve, you move a little more distally. The ulnar nerve splits into a motor and a sensory branch, and the motor branch goes very close to the hook of the hamate, and this is prone to injury when there is a fracture of the hook of the hamate. Right, so this is something that we can definitely try and quite easily identify on our ultrasound. Now, moving on from the wrist, I'll quickly cover up the structure of the fingers as well. So the flexor tendons, as we know, as we trace these tendons more distally and from the wrist, as they go into the palm and into the fingers, what happens is we are seeing these two tendons very distinctly. We have the flexor digitorum superficialis and we have the flexor digitorum profundus, right? So what is situated deep over here? This structure is your flexor digitorum profundus, and what lies superficially is your flexor digitorum superficialis. So if you observe this very keenly, as we move distally towards the fingers, the flexor digitorum superficialis is actually splitting into two. This is what happens. And the two slips of the flexor digitorum superficialis insert onto the lateral aspects or in the mid portion of the mid phalanx, right? So this is how we identify this is the flexor digitorum superficialis tendons. And whereas the flexor digitorum profundus tendon goes more distally and inserts onto the base of the distal phalanx, right? So you can see that this is the profundus tendon, which is going more distally. You can see that the superficialis tendon has split up and the profundus tendon is going more distally. It is deep situated and going more distally. These tendons can be very nicely evaluated on a longitudinal plane as well. You can very nicely see the insertion of this flexor digitorum profundus at the base of the distal phalanx, as you can see over here. And this entire tendon, the superficialis as well as the profundus, can be very nicely traced on ultrasound using our high resolution probes, right? And again, this is important when you're trying to look at any trauma and where you're trying to identify the site of trauma to these tendons. Another important structure which is lying just below these flexor tendons over here is the volar plate. And this is again something which can be injured with a hyperextension injury. So very rarely, once in a while, we do come across these pathologies as well. Now, the best part about using ultrasound is the ability for us to do a dynamic scan, right? So not only can we evaluate the length of the fingers, we can actually, see the function as to how these tendons are performing. So if you move the finger, you can see that the flexor digitorum superficialis as profundus are moving. If you want to evaluate only the profundus, you can, stabilize the proximal interphalangeal joint, move only the distal interphalangeal joint, and in that case, you can see only the flexor digitorum profundus moving, right? So again, very important aspect of ultrasound to evaluate these tendons on with a dynamic scan. The other important thing when it comes to the flexor aspect at the level of the fingers is the presence of the pulleys, right? So there are multiple pulleys. I am sure all of us know about it. And how they are seen on ultrasound is this hypoechoic structure, which is surrounding the flexor tendon and, kind of keeping the flexor tendon in place, right? So this is how the A1 pulley looks. This is A1 at the level of the metacarpophalangeal joint. You can evaluate the A2, A3, A4 pulleys as well. And the other thing which is important and which is very useful with the ultrasound, especially using our very high resolution transducers, is that we can now actually even evaluate the neurovascular bundles at the level of the fingers, right? So these are actually the digital vessels and the digital nerve next to it. So we can identify the pathologies involving these structures as well. The dorsal aspect of the fingers is relatively more difficult to, identify and visualize as compared to the flexor aspect, because the structures over here are very, very thin. So you have to use a lot of jelly. You have to, of course, use a highest frequency transducers to be able to identify these structures. And what you are able to see is the extensor tendon. Similar to how we saw the flexor tendon, you have the extensor tendon splitting into the lateral bands and inserting onto your distal phalanx, whereas the central slip inserts somewhere in the proximal aspect of the mid phalanx. And similar to what we saw on the flexor side, where we had the pulleys, you have these sagittal bands at the or forming this extensor hood, which stabilize the extensor tendon and prevent any lateral displacement. So again, using ultrasound, all of this can be quite nicely seen. So any injuries, any pathologies over here can be fairly easily identified. So now, once we have had a look at the basic anatomy of the structures, we'll move on to some of the common pathologies that we encounter. And for the ease of a discussion, I have just split this into a vascular, inflammatory, infective, neurogenic, traumatic, and miscellaneous pathologies. So we'll just see a few of them. Now, vascular malformations are something which are quite frequently seen on the hand because, especially they are quite frequently prone to trauma, right? And this typically present with a very heterogeneous appearance. You may see, some amount of arterial, some amount of venous flow. You can see this tangle of vessels. It's at times quite difficult to identify the feeding artery or the draining vein if it's an arteriovenous malformation, right? And if these are slow flow malformations, then you may need to give a little bit of compression to really see see the flow in these areas quite well. And ultrasound plays a very important role not only to identify, but suppose if you've done embolization for these vascular malformations or something to that effect, you can just follow them up using an ultrasound rather than needing to do an MR or anything else. And it definitely gives you an answer as to how well the surgery has gone off well. Hemangiomas can typically present with these phlebolytics that can give shadowing, and this is a clue that this can be a hemangioma. Like I mentioned, we do come across trauma to the finger very frequently, and one of the complications can be an AV fistula. So you can see dilated veins rather, and you can identify this kind of an arterial flow within the radial vein. Right, so this is a very good clue as to that this is probably an AV fistula. Now, coming to the inflammatory pathologies, which is what we see most frequently in the hand, right? And the Dick Irwin stenosynovitis, I'm sure everyone has heard about that, is one of the commonest problems that we encounter. So this is an tenosynovitis involving the compartment 1 tendons. So this can happen because of overuse. And what we see on ultrasound is the thickening of the sheath, right? So normally this is a very thin sheath, but here you can identify there is thickening of the sheath. There may be vascularity. You can always try to identify the vascularity, but it doesn't really always add up to anything. The thickening is what is more important. And this is another huge advantage of ultrasound. Sometimes when the thickening is very subtle and we have a doubt as to whether there is thickening or no, we can always go and do a quick comparison on the other side as well to get a quick answer, right? This can be associated with tenosynovitis. Not only, I mean, if you're looking at Decker veins, yes, there can be tenosynovitis of the tendon sheath. I mean, there can be fluid along the tendons as well. Tenosynovitis can occur along any of the tendons. Like I was talking to you sometime back about, the tenosynovitis affecting the extensor tendons. This is a very, very subtle tenosynovitis affecting the compartment 3 tendons. And the idea of showing this is, ultrasound is actually able to to identify these very subtle findings, right? And the other important thing is that, invariably you have the patient with you on the bedside. So you can actually ask the patient as to which is the site of pain, which is the site of tenderness, try and do a good, quick clinical correlation, and you actually fare much better. So yes, tenosynovitis is something that we can frequently see. This can go along the extensor tendons, the flexor tendons, or wherever. And when you do see tenosynovitis, sometimes this can be associated with a trigger finger, right? Especially if you're looking at pain in this region. And sometimes this patient can come with a trigger. So, they say that there's a flexion deformity, and the moment they try to extend the hand, it kind of clicks. And what you are able to identify is this pulley thickening, something like this over here. So normally a pulley is say about 3 millimeters or so in thickness normally. So if you if you 0.3 millimeters, I'm sorry, 0.3 millimeters in thickness. So if you see a thickening of the pulley more than that, you are potentially looking at a pulley thickening. And this can be associated with flexor tenosynovitis as well. But if you see this kind of a nodular appearance of the fluid along the tendon, you have to think of an inflammatory pathology. And this can go not only along the tendons, this is more frequent along the joint spaces. So if you look at the distal radioulnar joint space, you can see that there is some soft tissue proliferation over here, some synovial thickening over here. And you can identify even increased vascularity, or like in this case, there can be even bony erosions, right? So this entire spectrum of inflammatory arthritis you can potentially look at. We are increasingly nowadays using the Euler-Omerak PDUS scoring, so which grades the synovitis in terms of what we see on B mode, combined with how we see this on the power Doppler, how the vascularity is coming up on power Doppler. We assign it a particular grade. And when these patients come for a follow-up, we can evaluate this again. We can tell them whether the therapy is working or not working as well. And this is where ultrasound can, really help identifying these subtle thickening, subtle increase in vascularity. It's definitely very helpful. Infective pathologies are not something that we see very, very frequently. Once in a while, yes, you may see something like an infective tenosynovitis. You have a tendon which is thickened. You can see these kind of moving echoes over here. And of course, this patient will have a typical clinical profile, maybe a diabetic, maybe immunocompromised. He'll have a lot of pain, erythema, swelling over the joint, and this is how they typically present. But more often, we do end up seeing osteomyelitis, where you can have, inflammation of not only the tendon sheath, but you may have this spreading into different compartments of the tendons, different, layers. This may be a skin, subacute involvement, synovial thickening, multiple things. You may have even like bony erosions. So this is something that we do come across once in a while. Neurogenic lesions, as far as they are concerned, the commonest thing that we do encounter is the nerve sheath tumor, right? So nerve sheath tumor can, of course, affect any part of the nerve anywhere. And what we do see is this very classical appearance where we have a bulbous enlargement, a lesion which is traversing along the nerve. And the reason ultrasound plays a very important role over here is that you can actually trace this entire nerve, right? So even the smaller branches of the nerve, you can trace, you can see that this lesion is actually coming up along the branch of this nerve, which you can see identify over here. And you know that, yes, you're definitely looking at a nerve sheath tumor. And on ultrasound, you can get these very nice images, what we call as a rat tail sign. So you can see that this is the normal nerve on either side of this lesion. So we are very sure that this is a nerve sheath tumor. And the other thing is, like I said, because the patient is going to be with you, you can do some clinical correlation. So the moment you press on this area where you can see this lesion, the patient will, probably have this sudden tingling, numbness, or shooting pain. So you know that, yes, you're definitely looking at a neurogenic lesion. right? You can potentially differentiate between schwannomas and neurofibromas, though it can be a little difficult. But schwannomas may have areas of calcification or hemorrhage or something else. This is again something very important because of the advent of our very high resolution transducers. We can now look at these digital nerves, like I said. So, in fact, this was a patient who had a trauma, and you can see a very subtle bulbous lesion along the digital nerve. And this was actually a post-traumatic neuroma involving the digital nerve, which can be fairly easily identified with a high resolution probe. And if you do get this kind of a picture where multiple nerves are getting affected, so this was the median nerve, you have the ulnar nerve, the common peroneal nerve in the foot, you're thinking in terms of polyneuritis. And in fact, in India, we do end up seeing Hansen's once in a while, maybe once a year or once in 2 years, but we do come across this once in a while. And now coming to one of the most important and the commonest problem that we encounter, which is the carpal tunnel syndrome. So we have already had a look at the anatomy of the carpal tunnel, and we know that we can very nicely identify the median nerve. So the median nerve typically supplies these fingers. So you have the first three, and some the radial part of the fourth as well, which can be supplied by the median nerve. So we can identify the compression of the median nerve in the carpal tunnel quite nicely using ultrasound. So if you remember, I showed you a nice fascicular pattern or honeycomb appearance of the nerve when we saw it in the carpal tunnel. And the moment you have a carpal tunnel syndrome, because of the compression of the nerve, you do end up getting this kind of a picture where you see edema of the nerve, and there's a loss of that honeycomb pattern, there's a loss of that fascicular structure. And if you look at it in the longitudinal section, you can see that yes, the nerve is suddenly changing in diameter a little bit. So this is where we use our criteria of size, right? So we take the circumference of the nerve, and if the circumference is less than 10 millimeters square, we say that this is normal. If it's between 10 to 14 millimeters square, it tends to be borderline. But if the patient is having symptoms, and or if there's some positive finding in the nerve conduction study, and you're seeing a diameter of about 10 to 14 millimeters square, then you can consider this significant. And if you see an circumference, which is area which is going more than 14 millimeters square, you are definitely looking at a carpal tunnel syndrome, right? And one important thing that you need to do is, when you're doing these measurements, it's important that we do this measurement with a free hand, right? So if you use a ellipse, which may be given with the machine, which may be given with the machine, you may have a little bit of a challenge getting it. So using freehand and drawing this caliper is very, very important. And this is how you calculate the area of the median nerve, right? And this 14 millimeter square is fairly sensitive for saying whether this particular nerve is affected or no. The other important criteria that we use is that we look at the area of the nerve at the level of the carpal tunnel and at the proximal third of the pronator quadratus muscle, right? So a little proximally, we look at the level of the pronator quadratus. And if the difference in this area is more than 2 millimeters square, then again, with a good degree of certainty, we can say that yes, there is compression of the nerve, and there is a presence of this carpal tunnel syndrome. So again, what we are trying to identify is the presence of edema, right? So the moment there is compression of the nerve, what we get is edema proximal to the site of compression. And this is what we are trying to identify using our area parameter, right? There are a lot of other signs which have been described for identifying carpal tunnel on ultrasound. So you can have, something like a knot sign where the nerve flattens at the site of compression and it thickens proximal to the site of compression. You can always compare it to the other side. You can see that this is definitely more edematous as compared to this. And at times you may end up seeing something like a bowing of the flexor retinaculum as well, right? So normally the flexor retinaculum has a flattened appearance, but here you may end up seeing a little bit of a bowing. But as far as routine clinical practice goes, we rely on two things where we look at the area, number one, and second is the difference in the area at the level of the carpal tunnel versus the level of the pronator quadratus. Right, so this is what we lay a lot of importance on in our routine practice. But the other very, very important thing is that we have to rule out secondary causes of the carpal tunnel, right? So majority of the times when these patients present, we already know that we are looking at a carpal tunnel syndrome. Right, so we have to look out for any other causes if there's any ganglion or any tenosynovitis or anything which is causing compression of the nerve, because the management is going to be dependent on that. Now, coming to the traumatic causes, yes, if there is a presence of trauma, if there is a hematoma due to trauma, we can see a whole bunch of things. You can see presence of, hypoechoic areas if it's an acute fluid, or you may see something like this where there's an organized hematoma which is compressing the tendon or the nerve or something, right? And like I said, hand is something which is very frequently injured. We do see a lot of foreign bodies as well. And if there are foreign bodies, if there's like a wooden piece, it appears as this bright echogenic lesion. And sometimes you can see this kind of inflammatory response around that foreign body once a granuloma is setting in. But when you have a foreign body, one of the things that we need to try and identify is the presence of a tendon injury, right? So, like I mentioned, because ultrasound is dynamic in nature, we can actually identify the tendons very nicely. We can look at individual tendons. We can look at the flexor digitorum superficialis. We can look at the flexor digitorum profundus. We can identify the site of tear. We can identify the distance between the torn edges. Again, a lot of important data that we can provide to the surgeons. And of course, it's not only the tendons which can get injured. You can have injury to the nerve as well. For example, this was a penetrating injury where you had injury to the median nerve as well, apart from the tendons, right? So always we have to keep our eyes open. Again, a very important case where there was a suspected tear of the extensor pollicis longus tendon, the compartment 3 tendon, which is very thin, and at times very difficult to identify. So what helps over here is the comparison. So you can see that this is the compartment 2 tendon on the right. This is the compartment 2 on the left. This is the listers. And we should see this very small tendon sitting over here, but we are seeing that there's no hyperechoic tendon sitting over here. So your next step is going to be to try and trace the tendon and see where it's sitting. So if you look at this image a little properly, you can see that there's a bunched up tendon sitting somewhere over here, right? So this is where the retracted portion of the tendon was. So this was the proximal edge, this was the distal edge, and it is important, like I said, you mentioned how far, what is the gap between the two edges, and this is very important from a surgical perspective. But the best part about this is, we can identify these edges on ultrasound without really having to change our coil, without having to really, move the patient. All you have to do is just, mobilize your probe, move it a little proximally, move it a little distally, and you can get a whole bunch of this information. Very rarely you do end up seeing collateral ligament injuries as well. You can identify them, maybe a thickening, maybe a partial tear, maybe even a complete tear. But again, the idea of showing this is using our high resolution probes, we can identify these small structures like the collateral ligaments. A place where ultrasound plays a very, very important role is in post-operative assessment, right? So a good number of times these patients may not be in a position to undergo MR, or if you do undergo an MR, there may be some possibility of artifacts. Yes, there are, ways to suppress the artifacts as well now, but ultrasound provides a very, very easy answer. So for example, this was a patient who had tenosynovitis along the flexor tendon. So the patient initially had fracture. There was a screw plate put at the distal end of the radius. Patient came with difficulty in moving the fingers, And what we saw is that there's definitely some synovitis along the flexor digitorum tendons. And the cause of it was actually this orthopedic hardware, which was abrading against the tendon sheath, causing, repeated irritation. And as a result of this, there was a tenosynovitis, right? So very easily, we can really give up these answers on ultrasound. Now, coming to neoplasms, not something that we see very frequently, but what we do encounter frequently is lipomas. Again, very easy to diagnose clinically. On ultrasound, they appear as ISO 2 hyperechoic lesions. There's no vascularity. You see this very classical curved, echogenic lines parallel to the skin surface. But what is important is that we identify the plane they are in, whether they are in the subcutaneous tissues, whether they are in the intermuscular plane. If they are in the intermuscular plane, are they segregating, are they pushing different structures? So this is something that we need to give an answer on, and more important rather than just saying that there is a lipoma. Another common thing that we do encounter is the GCT of the tendon sheath. Now, this is actually a localized nodular tenosynovitis. So what we do see is this kind of a soft tissue, hypoechoic soft tissue adjacent to the tendon. It can show vascularity on Doppler, very, very closely associated to the tendon sheath, eccentrically located to the tendon, something like this. And if you move the tendon will actually show a normal movement, right? So again, that's something that you can do dynamically on your ultrasound. And at times, you may see this kind of a picture. You may see this little bit of a scalloping of the bone. So all very classical features of a GCT of the tendon sheath. Once in a while, we do come across a glomus tumor, which is a benign vascular tumor at the base of the fingernail, extremely sensitive to touch. But once you put your probe over here, you can see that you can actually identify the nail bed over here. So this is again the magic of high resolution ultrasound. You can identify the nail bed. You can identify that there's a lesion sitting over here, which is a very vascular lesion in subungual location. So we know that yes, you're potentially looking at a glomus tumor. And again, if doubt persists, you can always go and compare to your other side. So this is again, I'm stressing on this because these are just some wonderful images, and every time you see this on ultrasound, it kind of carries you away. But you can see these nail beds and structures like this so very nicely on our ultrasound. And then we can once in a while come across things like epidermal inclusion cyst. I'm not going to be stressing on that. Pseudo-rheumatoid nodules, which can come up in a young age group. They are painless solitary masses. Nothing really needs to be done for them. You just follow them up, then they shouldn't be a problem. You can encounter soft tissue calcifications in cases like scleroderma. Again, this is not very frequent. Once in a while, you can come across. But if you're talking about the wrist, the most common thing that we really encounter is the ganglion, right? So I'm sure all of us have encountered this, which is a cystic structure and filled with mucinous material. And wrist is a very, very common location of the ganglion cyst, right? So commonly found somewhere dorsally over the scapholunate ligament on the volar side between the radial artery and the flexor carpi radialis tendon. Again, it's a painless mass. And again, majority of the times, the clinician is aware that this is going to be a ganglion cyst. Our idea is just to confirm the diagnosis, tell them the location, and also very important aspect is identifying the relation to the adjacent important structures, right? So if the surgeon is going to go in and excise, you want to know where the radial artery is, whether nerve is, so that is the information that we really need to give them. The other thing that we need to tell them is where the ganglion cyst is coming from. And majority of the times, there is a communication with the bone, so or the intercarpal joint spaces, right? So if you make a little bit of an attempt and give it a little bit of a hard look, you will be able to identify this kind of a very subtle, stalk kind of a thing which goes all the way somewhere towards the bone, so that you know that yes, this is probably arising somewhere from the joint spaces. Very rarely you do have ganglions coming up from the tendon sheath, or very rarely you can have them located within the muscles as well. So thank you for a patient hearing. The idea of this talk was just to let you know how wonderful ultrasound can be as a primary modality, and there are a whole lot of answers that we can really go in, and not every case of wrist will probably need an MRI for a diagnosis. Thank you.
Awesome. Thank you so much, Dr. Trouble, for that lecture today. I think I see one question popping up in the Q&A, if you want to open that up and start answering some of those.
Yes. Okay, so the question over here is, where should we measure the median nerve, before or in the canal? Okay, so the like I showed you, there are two places where measurement is most important. One is at the site where it's entering the canal, so at the proximal edge of the carpal tunnel. And then we measure it somewhere a little more proximally at the level of the pronator quadratus, right? So you're actually able to see this pronator quadratus and the pronator quadratus muscle, and that is what we use for identification. Having said that, the median nerve compression can also happen within the tunnel. It can happen distal to the tunnel. So it's always a good idea that you trace the entire aspect of the median nerve till it branches out, and you may end up picking up some compressions over there as well. Okay, so somebody is requesting for a TFCC again. I'll show that, but TFCC is not something that we really go all out and gung ho on ultrasound. But yes, if you do want to evaluate the TFCC, sorry, I'm trying to share my screen again. Uh, I'm just trying to pull back the slide of the TFCC. Yeah, there it is. Yeah. So what we do is, with the hand in the radial deviation, right? My idea is first identify the extensor carpi ulnaris tendon, right? And just below the extensor carpi ulnaris tendon, I do end up seeing, oh, sorry, I'm sorry about that. I'm sorry about that. Yeah. And just below the extensor carpi ulnaris tendon, I end up seeing this structure over here, and this is my TFCC. So again, it is not, you may not be able to see the deeper aspects of the TFCC, so you can't always say whether there's an injury or no. But at times, if you want to inject into the TFCC, this is, something like a landmark that you can use if you want to do that. So there's a question, do you use comparison everywhere in a borderline median now, or always? Okay, so if you go back to, in fact, I'll try and show you this slide again. Yes. Yes. So, see, if you look at this slide, when are we looking at carpal tunnel syndrome? Now, majority of the times when these patients come in, we already know there's a carpal tunnel syndrome, right? So again, one of the ideas is to confirm, and the second is to rule out any other, secondary cause of the carpal tunnel. That is what we want to do on ultrasound. Now, if you have a patient who is symptomatic, right? And you're getting these values of, say, about 10 to 14, then yes, we can say that, there's potentially a carpal tunnel. And yes, in these cases, I would want to compare with the other side and see if, how the other nerve is looking. But if you have nerve which is very significantly enlarged, maybe 20 millimeters square or so, you can say with more certainty. And, in those cases, you may not always need a comparison, but it's always maybe a good idea to just have a look at the other side. And I think that's the advantage of ultrasound. You don't really need to put the patient in the gantry again. You don't need to change the coil. You can just quickly place your probe on the other side and get a quick answer. There's a question, what is the norm of ulnar nerve in the Gans canal? I didn't quite get it. What is the norm, as in if you could just dimension. Okay. Sorry. Okay. Actually, we don't really bother about the dimension of the ulnar now. Again, what if I'm thinking in terms of compression, what I would probably want to look at is, if there's any edema proximally. I don't always really get into the dimension and, really measuring the ulnar nerve over there. So maybe there is a normal number which maybe we can look up and have a look at that.
I do see one more question just popped in. If you want to answer that one, then we can wrap this up.
I think about the dimension, I think I answered that.
How to identify the ulnar artery and nerve in Guyon's canal.
Oh, I couldn't see that. Sorry. Okay, so
You're good.
how
It just
do
came through.
Sorry?
You're good. It just came through 1 second ago.
Oh, okay, fine. Okay. So how do you identify? So actually, it's fairly easy. Okay, so what you do is I'm going to go back to my presentation. Make it a little bit easier. Yeah, there you go. Okay. So what we do is, what we're doing is using the pisiform as a bony landmark, right? So once you identify the pisiform, bang next to that, if you turn on your color Doppler over here, you'll see this pulsating vessel, which is your ulnar artery. And if you look at the structure lying between the ulnar artery and the pisiform, you will be able to identify the ulnar nerve. Again, once you start looking at ultrasound, you realize that, everywhere all nerves are going to have that kind of a honeycomb appearance, right? So whether you're looking at the ulnar nerve, whether you're looking at the median nerve, whether you're looking at the radial nerve, once you're in a section, you kind of pattern. So it's this, but you'll see that honeycomb pattern. And that is what will help you to identify and say that, yes, this is the ulnar nerve. But like I said, what helps you over here is using the pisiform as a bony landmark, and you can identify the nerve quite quickly over there.
All right. I think that is our final question that just came in. So I just wanted to say thank you again for that lecture today and all of your questions, answering all those questions for us. And thank you to all of you for participating and asking these awesome questions. You can access the recording of today's conference and all previous noon conferences by creating a free MRI Online account. We'll also email out a link to the replay later today. Be sure to join us next week on Thursday, July 11th at 12 p.m. Eastern Time, where Dr. Felice D'Arco will deliver a lecture entitled Pediatric Epilepsy: What the Radiologist Needs to Know. You can register for that at mrionline.com and follow us on social media for updates on future noon conferences. Thanks again and have a great day.
Thank you. Bye-bye.